Morning, everyone, and welcome to the 2024 NCIC Symposium on a really important topic on which we're developing a lot of new information on how we tackle fungal infections. So before we start, I'd like to respectfully acknowledge the traditional owners of the lands on which we meet today, the Wurundjeri people of the Kulin Nation, and pay our respects to elders past and present. I'd also like to make a couple of quick announcements, and that is to thank Pfizer for providing refreshments and to very much thank our organising committee, ably chaired by Associate Professor Michelle Yong, and including Nikhil Singh, Priya Garg, Zoe Neo, Megan Crane and Abby Douglas. Thanks for lining up this great symposium today with fantastic speakers. We're going to hear presentations by 5 speakers, followed by a panel discussion. So we're going to save any questions for the end, but please do put your questions in the chat as we go along. And at the end, you'll also have the opportunity to directly ask questions as well as via chat. So I'd like to now turn to our first speaker, who really needs no introduction. It's Professor Dimitrios Kontoyiannis, who is the Robert C. Hickey Chair in Clinical Care and Deputy Head of Research for the Division of Internal Medicine, University of Texas, and MD Anderson Cancer Center. Dimitrios is a friend and mentor to many in mycology. He's been a thought leader in mycology, always exploring cutting-edge translational science in his work. He is highly published, probably the most highly published researcher in mycology, but apart from that, he's a wonderful colleague who's always supportive of junior staff and mentoring people. We're very privileged to have him to join us today to talk about immunotherapy for mycosis, one of the areas that he's currently heavily involved in. Over to you, Dimitrios, and thank you.
Thank you very much, Monica, for the most kind introduction. And thank you very much for inviting me to this wonderful symposium you have. Those are my disclosures that are not pertinent to what I'm going to talk about. So I'm a clinician at heart, and most of my clinical work is in leukemia, transplant, and lymphoma. So I thought in these 25 minutes or so to give you a clinical talk based on a real case I had in July, and actually they've been emailing me 5 minutes ago what to do with this patient. That was a really challenge for us. I review a little bit of the old players in immunotherapy we contemplated to use in this challenging case. And this gives me an opportunity to conceptually discuss the confounders and other problems in, as we say, knowing the truth about the significance of immunotherapy and how challenging it is to dissect its impact. And then I'm going to have some thoughts. I've been working lately in a review how to understand better clinical trials and what do we need to do to justify impactful clinical trials immunotherapy. Initially, I was asked to give some talk about checkpoint inhibitors, and I'm going to throw some investigational work we do on that area, and I'm going to end up with some final thoughts and conclusions. So this is a really challenging case we had in July, a 36-year-old physician assistant from rural Illinois who came to MD Anderson in early July with a newly diagnosed AML with a 93% blast. She started clear in cortisone chemotherapy, and she was put on caspofungin prophylaxis because of concern of drug-drug interactions with azoles. On admission, she had the typical AML profile, 80% blast, neutropenic, pancytopenic. And on admission, basically, very early on, she had the baseline CT that showed nodular opacities with ground glass halos, suspicious for fungal infection, very early on her presentation. So I was consulted with this. Caspo, that was not around for a long time, was changed to posaconazole. She had a bronchoscopy that was negative. Fungal biomarkers, typically here we do galactomannan, has been negative. asking the patient, because as you can imagine, it's very unusual to see newly diagnosed AML, putative fungal pneumonia. Usually this is a problem of later for salvage therapy of AML, relapsed AML, refractory AML. And the patient told us he had a chicken coop and she was exposed to all kind of farm environment, earth, moldy environment that made sense that she had some kind of high inoculum fungal disease. So then, because back then ID put her on a more broad spectrum, agent, posaconazole, and because the patient was asymptomatic, they put her on posaconazole, documented a decent level of about 1,000, and sign off. And as you can see here, this is the baseline. CT shows this classic subpleural nodular airspace disease consistent with fungal pneumonia. However, within about 2 weeks after she started on this posaconazole, she develops a new right maxillary pain. CT of the sinuses showed mucosal thickening and air fluid level. We have a protocol here, and we have very rapid deployment of ENT for endoscopy. They found some inflammation in the right mucosal of the maxillary sinuses and some turbinate hypertrophy, nothing major. They did some tissue culture swab that grew coagulus negative stuff. However, the patient continued to do worse, and then MRI of the face this time showed an evolution of her problem with necrotic mucosa and bone involvement, edema in the periorbital soft tissue, and the patient started having right-sided proptosis clinically. Ophthalmology saw the patient, she had an evidence of involvement of the right lacrimal sac and possibly some inflammation of the medial orbital wall. Then we kept pushing endoscopy here, for people, you already kind of suspect what she has. It's very important for the young people to understand that one-time imaging, one-time endoscopy is not sufficient in this patient. You need to keep doing it because the patient can have a problem that can have a catastrophic or very rapid evolution. So in the endoscopy was done again. She found this time necrosis in the sinuses. This is the proptosis she had. The MRI that showed basically some bone involvement in sinusitis. Then she was taken to OR 3 times, necrotic tissue, dusky mucosa, fungal elements in pathology they couldn't differentiate whether it was hyphomycetes or mucorales. But at the end of the day, the cultures did not grow anything consistent with the fastidious nature of mucorales, but immunohistochemistry was positive for rhizopus. And so the patient had a fairly well-documented ranorbital, rapidly progressive mucormycosis, and the MRI was consistent also with this involvement of early involvement of the orbits. And as you can see here, the evolution of her MRI, that is very worrisome. As you can see here, the orbit lights up. The inflammation was right there in the orbit with ptosis and proptosis. Then obviously, that's where I came in the service, and this is a lot of things we threw at this patient, and that's the basis of what I'm going to talk about. We changed liposomal amphotericin B. We increased the dose of posaconazole aiming at high posaconazole level. We covered for concomitant bacterial co-infection. We kept pushing for OR debridements, and she had basically several debridements within 5 days because of this threatening infection on her orbit. ENT started nasal rinses. Then I talked to ophthalmology, and we instituted retrobulbar amphotericin B injections, trying to extrapolate from the experience from India with an orbital mucormycosis in the setting of COVID. And then we start talking to leukemia attendings, what else he could do. The patient was pancytopenic. Can we do cytokines to boost her immunity? Can we do white cell transfusions? And after a lot of debate, we started her on a combined recombinant GM-CSF and G-CSF that she took for about 7 days until the best antifungal drug known to God, called neutrophil count, came back and the patient went into remission. And for people who want to see a rather barbaric, I would say, procedure, there is also some videos on YouTube how you do retrobarbal amphotericin injection. The patient had a lot of pain during those procedures. At some point, she refused to have further procedures. And coming back to my talk, let's think about this patient. This patient had combined broad-spectrum antifungals, ambisome and high-dose posaconazole. She had 3 debridements. She had local treatments with nasal rinses, retrobarbal amphotericin B, started GM-CSF, G-CSF, and improved only when counts came back and went to remission. So for the clinical people in the room, you probably have the same question I have. How one assess the impact, if any, of any immunotherapy in a patient who had multiple interventions, concomitantly and sequentially, in a very dynamic state of her immunosuppression? And this is, I think, the key problem. And that's why immunotherapy and all these ideas has been around for almost 40 years. I'm going to talk to you later on about this, how it's controversial to dissect the impact of immunotherapeutic interventions. But let's go about cytokine, adjunct cytokines for refractory IFIs. There is a disconnect between very convincing literature, most of them in vitro studies, and salvage case reports. You know, the patient was dying, we gave him a cytokine and the patient recovered. But if you see critically, and now I'm putting my laboratory investigator hat about all these in vitro reports, they're very artificial. They use immune cells from healthy donors. They play around the game. They use favorable effector cells to target residues, more cells over the fungi. The few animal models used out there are totally artificial because they use high fungal inocula and iatrogenic immunosuppression. In other words, and I'm going to come to this point later on, they don't mimic the underlying malignant disease. Then there is a big gap about primary data, and then you go to a bunch of anecdotal data that have obviously reporting biases, publication biases. Importantly, there is no denominator, and very, 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 very importantly, they do not account for the recovery of immune deficits, like in this patient, neutrophil recovery or CR. In other words, and this is a major problem in salvage therapy overall, and that's why you see a salvage therapy response rate of 40%, irrespective of the intervention. This is I think, the confounder of immune recovery, and that's the problems of salvage therapy. Also, oncologists, if you talk to oncologists, especially some people who are junior faculty and they are afraid they're going to do the wrong thing, they are very concerned about this urban myth. We have a lot of urban myths in mycology or infectious disease, like bacterium suppresses bone marrow or whatever, but oncologists are afraid that growth factors can stimulate the leukemia clone and result in cancer progression. And also toxicities is an issue. If you had patients, especially on combination of GM-CSF gamma interferon, and I had several in my career, they look beaten down like I had bad flu, they have fevers with interferon, they feel awful, depressed. It's not an easy regimen to tolerate. And as I said before, there are a lot of preclinical data. I think Tom Walsh has done wonderful work in this area. One of the best papers was in JID 20 years ago about gamma interferon GM-CSF for mucormycosis, and also a recent work with no denominator, kind of a compilation of cases that was published in OFID, suggested that, you know, if you add recombinant GM-CSF, you have a very good response rate in the salvage setting. But with all these confounders I just talked to you about. So we were kind of interested in those data, by no means good quality, publication grade data, and we're looking more carefully in this data, but I was interested to know what happens if we have a denominator. And here we see our experience with salvage GM-CSF and/or G-CSF in patients with refractory aspergillosis, typically in the setting of refractory leukemia or refractory graft-versus-host disease. These patients, because we want to have a clean population of the worst patients, have culture-documented disease, or neutropenic, malnourished, low albumin, and active hematologic disease, and high overall background of mortality. So there is a sense, maybe a signal, maybe not. We didn't have too many patients, only 26 patients, that if you start GM-CSF, maybe mortality is better, but obviously those data have a lot of confounders, a lot of heterogeneity. So we're looking more carefully, but what I learned here is if you put a denominator, data don't look as good, and probably they don't look good if you start recombinant cytokines in the salvage setting in a very high background of mortality in those patients. And that's another depiction of this tremendous heterogeneity of immunotherapeutic intervention. This is from a review we wrote in Frontiers Immunology about checkpoint inhibitors. And as you can see here, underlying disease all the way from normal host with trauma, diabetes and COVID, AML, different types of mucormycosis, all the way from GI to an orbital disease, different type of interventions, like this patient had a lot. The timing of immune checkpoint inhibitors and dosing varied. Other cytokines may have been added. Outcome was assessed as crude mortality, not attributed mortality, and few cases had surrogate immune enhancement measured to correlate any salutary effect of checkpoint inhibitors with immune restoration. I'm going to come back to checkpoint inhibitors towards the end of my talk. So in terms of white cell transfusions, this audience is sophisticated enough. I'm not going to belabor to this slide, but having white cells is great. It kills the fungus through oxygen-dependent and non-oxygen-dependent toxicity, has also web-like extracellular traps. It's just great. However, if you go to this idea, that this idea is not new. Actually, this idea was there before I was born in the early 60s by the great J. Freireich. That say, okay, we can do white cell transfusions from donors to abrogate, infections in patients with CML. So very old idea. But this idea, almost 60 years, almost more than 60 years afterwards, has not become a mainstream idea to medical oncology. First of all, techniques and methods were very cumbersome. Early on, Buffy code, then CML donor that had a risk of leukemia, apheresis that had low yield and variability in viability of neutrophils. Then some big push happened with G-CSF or GM-CSF stimulated healthy donors that they give, blood and bone marrow, and then they collect and they give it to the patient. First of all, this is very taxing logistically. I mean, if we have patients out of town in Houston, the family needs to fly in a couple of days. It's not real time, very expensive, very difficult. Unknown target of cells. Toxicities is a major issue. And in this particular patient, I talk a lot and I fought with leukemia because I was really concerned about orbital necrosis if we put too many neutrophils in this closed space infection like orbit. If you talk to transplanters, also there is an anathema in transplant world about white cell transfusions that are non-radiated because there is concern about transfusion-associated graft-versus-host disease, and there are strong opinions. It works, it doesn't work, radiated white cells, non-radiated white cells, and therefore, the only randomized study that was done, the RING study, failed, was underpowered because of slow recruitment, disagreement between blood banks, how to do it, etc. This study had mixed indications of infection, very few IFIs, but if you see carefully this study, there was an apparent dose effect. People who had high concentration of white cells fared better for the infection compared to the ones who have low white cells. This is the best data out there, the RING study that was published in blood 10 years ago about white cell transfusions. And then, because of all these controversies, then, I witnessed the revolution of oncology, which is two revolutions this in my career, which is cellular therapy and the non-cellular, pleiotropic adjunct, immunomodulators. This is checkpoint inhibitors that basically counteract immune exhaustion in the cancer microenvironment and activate T cells that kill the tumor, etc. So we asked the question, can that happen also for chronic infections? And there have been very good data in HIV, CMV, chronic infections, viral infections that, as you know, are associated with immune exhaustion. And to make the long story short, there is abundant evidence, experimental and emerging clinical evidence, that this might work also for chronic fungal infections. Those are the two papers we have published, and I'm going to show you some unpublished data. What is impressive about those data, obviously, it's an iatrogenically, induced immunosuppression in healthy mice otherwise, so I'm going to criticize my own, approach, number one. But here you see survival benefit with checkpoint inhibitors without antifungals. So checkpoint inhibitors alone for both Aspergillus and even more impressively with Mucorales pneumonia protect from death. And we have surrogate markers with fungal burden, histopathology, and ex vivo assessment of neutrophil recruitment and effector cell function against a lethal infection. Actually, data I'm not going to show, if you combine them with some other antifungal immunomodulators, such as caspofungin in aspergillosis, you see a very powerful synergy between checkpoint inhibitors and antifungals. And now those are data that we haven't published. We presented them. I think Monica was there in my course study group when we were interested not on the scenarios we see that late immunotherapy, but what do we do if we combine a checkpoint inhibitor with or without a classic immunomodulator like gamma interferon or GM-CSF early. So we look in this problem, early immunotherapy versus late immunotherapy, and the bottom line is, and we use a surrogate endpoint of morbidity, sickness, and mortality, and the bottom line is early immunotherapy wins every day compared to late immunotherapy. In this particular data, we combine immunotherapy with an antifungal called sabuconazole. And in mechanistic studies we have done, and Sebastian Wooster in my group has been leading this idea, we have found basically that what happens, especially for Mucorales infection, you get an early immune activation and then a profound immune paralysis, immune exhaustion. And PD-L1 based therapy reverses this immune exhaustion and restores competency of immune cells in the fungal microenvironment. In a way, we start thinking like oncologists with the tumor microenvironment. We think we go to an overdrive to overcome this immune exhaustion caused by Mucorales, probably due to a mycotoxin, I would guess. And those are the data we're working on in a publication we're to put together. But going back to say, okay, we have some interesting checkpoint inhibitors, what cells make sense, we can combine them with good cytokines like GM-CSF. What are the issues here? What we cannot do that. And I'm going to just only focus, because I don't have much time, about the things in yellow. What is the optimal dosing? What is the timing? What is the sequencing with conventional agent? How would assess efficacy? I'm going to come this to a point, and logistics and cost effectiveness. So if you are a young person in the audience, you say, okay, Dimitrios is giving us some kind of excitement with immunotherapy. I'm going to make a career out of myself to do an immunotherapy studies. I'm going to challenge you to think about these questions. What is the trial design? I don't think we can do a randomized control study. Is it open label? Can we use historical controls? Who will be the partner? and comparator, an investigational antifungal like, say, fosmanogepix, or a conventional drug, immunotherapy or combination. Can we do a non-inferiority or superiority design? I'm going to come in a moment and tell you probably the superiority design is a thing of the past. Could a future trial benefit from cluster randomization or composite endpoints? Something that is interesting for both aspergillosis with galactomannan and mucormycosis with quantitative PCR. How many clean patients one can enroll? I saw you very clean patients with newly diagnosed AML that had so many confounders. Can we use non-culture-based diagnosis, doses administration? How we evaluate success? Time to respond, time to death, when death is assessed, how is crude mortality appropriate, or can we look for attributed mortality? And how we assess toxicity in those patients, obvious or occult, due to inappropriate inflammatory response syndromes. And these are very nice editorial I always saw by Rich Wenzel about called the fragile anatomy of crude mortality. So basically, you have the mortality due to underlying diseases and comorbidities and attributed mortality that has also different components. So it's very difficult to dissect. And the way we do clinical studies those days is very difficult to know what is true here, whether the drug works or doesn't work because we look in crude mortality. But a very nice paper just got published in CID from the Netherlands experience when they have a lot of azole-resistant aspergillosis. So they thought, why we combine as an echinocandin and atrazo in this high background scenario of azole resistance and see if there is a benefit. So 5% of patients who were screened were enrolled. Recruitment was hampered by competing studies in hematology, a very important problem here. A lot of people go to prioritization to hematology-based trials, so all these trials are low priority. And basically, if you can see the total mortality in modern patient cohort was not bad, was 25%, and attributed mortality was even lower. So in a way, it's very difficult to do a randomized control study in opportunistic mycosis with clean patients that has an endpoint of crude or even attributed mortality that is the cleanest way, and how you need hundreds of patients. This is not feasible. So other things to think about for immunotherapy is leukemia AML has become an immunologically active area. The blasts were thought to be immunologically inert creatures, but everybody now is attacking blasts with T-cell therapy, design drugs that affect the immune environment, even checkpoint inhibitors. So any immunotherapy, cellular therapy or non-cellular therapy, in an opportunistic infection in myeloma, lymphoma, transplant, or leukemia needs to take into consideration what other plans for immunotherapy are to happen in this patient. Are we going to see synergies here? Are we going to see neutral effects or antagonists with our own intervention? And this is a review of the many reviews out there that makes the point that in almost 2025, in hematology units, we have so many drugs, monoclonal antibodies, and not only, that have pleiotropic effects to the immune system, neutropenia, serum immunoglobulins, T cells, B cells, etc. So the challenge is how to have a sense of the quality and quantity of immunosuppression in patients who have opportunistic fungal infections. So we got a small NIH grant, and we have established a leukemia model, AML model of fungal infections. We have a reproducible, basically, fungal pneumonias in this AML model with a lower dose than the high dose of fungal inoculum. And we're excited to raise the bar, I think, for all these interventions, immunotherapy, checkpoint inhibitors, chemotherapy, co-infections, sequential infections, moving from the iatrogenically mouse model to leukemia models, and see how much of these interventions might hold true if we have an underlying disease and not a healthy mice who got a bunch of steroids and cyclophosphamide. And we're excited, sort of, some kind of catastrophe with the elections in the United States. As you can see, it's a circus here with the elections. We got a fundable score, a very good score, to study in a multi-level way mucormycosis, pharmacotherapy, immunomodulators, antiviral strategies, in collaboration with Ashraf Ibrahim in UCLA, George Hamilos in Crete, Vince Bruno in Maryland. And we hope with this hard work, we're going to try to find prognostic markers and risk stratification based on immune parameters, when to do immunotherapy, how to do immunotherapy in real patients based on patient specimens, biospecimens, and also appropriate mouse models. So to give you a follow-up about this patient, they just emailed me just 5 minutes ago before I logged in. She's going to transplant this Sunday. She did very well with, neutrophil recovery and complete remission. We follow her very closely. ENT ophthalmology imaging did fine. The only problem she had is some creatinine elevation with ambisome that would change to twice a week. Interestingly, she got some maintenance, consolidation chemotherapy. She had new orbital pain and tenderness and very mild proptosis that went away as soon as we crank up the ambisome and posaconazole and gave her recombinant G-CSF. Interestingly also, because she had this open wound in her sinuses, she grew also stenotrophomonas, and her improvement also coincided with us giving her some therapy of stenotrophomonas. And the patient is doing fine, is going to be admitted, and they emailed me 5 minutes ago what you want to do with ambisome, and I told them to continue 3 times a week. So to conclude, the factors contributing to failure to immunotherapy or to success immunotherapy are multiple interrelated. And this is, I think, a very complicated, nuanced area of medical mycology that speaks for the importance of individualized approach. And this is the key challenge for immunotherapy trials. This is from a review we wrote 15 years ago about so many factors affecting outcome in those patients: sanctuary site of involvement, comorbidities, GI function, net state of immunosuppression, co-infections, diagnostic certainty, pathogen virulence, something we don't apply to the clinical settings easily, very important pharmacology, PK/PDs, and also resistance, but not only resistance. That if you go sometimes to a conference, you think the only thing that is important in medical mycology is resistance. It is important, but not the only important thing. Actually, the host is the most important thing, in my opinion, and that's why I think conceptual immunotherapy strategies is the future. It just, I think we need to do a better job understanding the human fungal immunity responses, not only from mice, to have intelligent studies, probably small studies, proof of concept studies in immunotherapy. And as I said before, all these confounders are there. And I'm going to finish here. Thank you for your attention, and I'm going to stay till the end for any questions. Thank you.
Thank you so much, Dimitrios, and thank you for that really sort of provocative and challenging talk about how we're going to deal with the assessment of immunotherapies and what the future of antifungal treatment is in this complex patient group. So I really appreciate that, and thank you for staying around for questions at the end. So we may move on now to the next talk, and we're very delighted to have Professor David Gottlieb, who's Professor of Haematology at University of Sydney and Senior Physician on the Westmead Hospital Blood and Marrow Transplant Unit, as well as being Medical Director of the Sydney Cellular Therapies Lab. David's really led the science and clinical evaluation of cellular therapy, particularly for treatment of infections internationally. He's trained many of our colleagues and has worked with many of us over the years on grants, projects, and trying to deliver immunotherapy to our patients and T-cell therapies to our patients. So it's really a great pleasure to have him as the expert today, talking to us about third-party fungal-specific T-cells. Thank you, David.
Thanks very much, Monica. Thanks to you, and thanks to Michelle for the invitation to speak here. So I'm going to talk about a specific approach that we're taking with T-cell therapies, third-party T-cells. I don't need to dwell or spend any time on this slide because this is a very sophisticated ID audience. But I'm a stem cell transplant physician, and so we focus most of our attention on aspergillosis, to some extent Candida, and of course the mucorales as well. So these infections, of course, are well known to you. Maybe what's less well known to you is some of the details of antifungal immunity. So I might just spend a little time on this slide, which comes from Dr. Ramani from Perugia. And this slide's now 20 years old, but I think it's still relevant. So thinking about the immunity to fungal infection rather than the fungal infection itself, I like to think of this in two parts. There's the innate immunity, so neutrophils, monocyte macrophages, and dendritic cells. So these cells encounter invading fungi close to epithelial surfaces. They recognize the presence of those fungi through pattern recognition receptors, principally C-type lectins and toll-like receptors, and they respond, of course, by a process of ingestion and destruction of those fungal infections as they're able. But of course, there is also this crossover where the dendritic cells play an additional role, and they activate what I call adaptive immunity. So adaptive immunity means T-cell responses, and those T-cell responses, as shown on this slide, can be Th1, which is a pro-inflammatory response characterized by the secretion of interferon gamma and TNF-alpha, Th2, which is more an allergic or down-regulatory response, regulatory T cells, and not shown on this slide because of this paper was published 20 years ago, is a Th17 response characterized by IL-17 production, which is a cytokine that activates neutrophils to deal with extracellular pathogens. So many of you will have now heard about adoptive immunotherapy or T-cell therapy, and just kind of to summarize where we're at with that. So the earliest form of T-cell therapy, as probably the Baylor group in the US was the first to make this popular, and used the stem cell donor, if we're talking about bone marrow transplant, used the stem cell donor as the source of material for the creation of an immune therapy by taking blood from the donor or from the product prior to the transplant, expanding virus-specific T cells in the laboratory, and then giving them back to the patient. And of course, this proved to be pretty effective, but it does have its problems because the product is from the donor for a specific recipient. It's a kind of clunky procedure, it's time-consuming, it's expensive, and it's very patient-specific. So an alternative approach to this has been the use of third-party donors. And in this paradigm, we're not using the stem cell donor. We're actually taking starting material from normal donors who've got common HLA antigens. I'll explain to you in a second why that is. And then doing the same sort of procedure. So we expand these cells in the laboratory, but we're then able to freeze them down in banks where the cells can be immediately available. So how does that work? Well, imagine now that you have an infected recipient cell. The infection then is processed. I'm not sure whether you can see this, but now we have an infectious antigen presented on the surface of this HLA molecule. Let's assume now then we have a third-party T cell, and that third-party T cell has a receptor, as I'm showing you here, for that infectious antigen. And in its native environment, it is seeing that same antigen presented on this same HLA molecule. So I've displayed that as HLA yellow here, and in its native environment, this receptor is capable of seeing the antigen on the surface of that HLA molecule. And when that happens, it is able then to recognize that antigen on the surface of the HLA molecule and destroy that particular cell. But a key thing here is that the antigen has got to be a dominant or a subdominant antigen, and it has to be, that recognition has to be through that shared HLA molecule. Now, this kind of approach has been pioneered really by the Baylor group, by Ann Lean in Houston, and really initially with viral infections. So on the left here, you can see the results of a trial in refractory viral infections post-bone marrow transplant, where the use of these third-party T cells led to overall response rates of around 75% in patients with refractory virus infections. We did a very similar study, followed these patients out a little bit longer because we weren't sure how long these responses would last, and found that out to about a year, we had overall response rates in excess of 90%. So this therapy really seems to work. And in our trial, we showed these are principally CMV infections, but where you gave these third-party T cells to patients that had required really long periods of antiviral treatment, you could cut short the antiviral treatment quite substantially. So on the left here in the red, you see the duration of antiviral treatment for CMV in most of these cases, lasting in some cases up to 3 or 4 months. And our ability then after the T cell infusion to cut short these periods of antiviral therapy. And we wondered, would it be possible to do the same with fungal infections? Now, most people who hear about T cell therapy now think immediately about CAR T cells. Everyone's heard about CAR T cells. And these CAR T cells are chimeric antigen receptors. So we create a new receptor in the T cell. We take genetic material encoding the single chain, the variable region of an antibody. We hook it up with a spacer, a transmembrane region, and then an intracellular section derived from the normal TCR complex, the CD3 zeta. And there are various iterations of these CAR T cells that have been made over the years by adding co-stimulatory molecules into the intracellular portion of the receptor. Okay, that is not what I'm going to talk to you about today. We have another speaker who's going to talk about that. I'm going to show you some information from a third-party trial that is not involving CAR T cells, and the cells that I'm talking about are not genetically modified. They are not derived from the donor. They are third-party cell derived, third-party donor derived, and they're not, as I explained to you before, fully HLA matched with the patient. They are T cells that we have expanded in vitro, and they retain their native T cell receptor. They don't have to be transduced or transfected. We hold them cryopreserved in banks, and they're immediately available, and they're matched in terms of tissue type with the patient at only 1 or 2 HLA-DR molecules. So we don't really know what the fungal antigens are. Fungal walls are complex things. They're made up of mannans, which are polymers in which the principal sugar is mannose. Glucans, of course, which are polysaccharides derived from D-glucose. Chitin is an important component. That's a polymer of N-acetylglucosamine. So there are many potential antigens, and we don't really have a dominant antigen that we know. So our approach to that was then to make a water-soluble lysate. We chose to make lysates of germinated Canidia of Aspergillus terreus and Candida krusei. I won't go into all the detail of that, but we did that principally because of some cross-reactivity studies we'd done very early. So we did these individually. We created these lysates. We pulsed these lysates onto antigen-presenting cells and then showed those antigen-presenting cells to unstimulated lymphocytes. We left those cells overnight, purified the activated cells being the ones that express CD137, and then expanded those in vitro. And these cells, when you do that, they grow very well. I won't show you all that information, But it turns out that the majority of the cells that you get are CD3 positive cells, and of those CD3 positive cells, the majority, not exclusively, majority are actually CD4 positive. They have largely an effector memory phenotype, but there are some naive T cells and some central memory cells there, and they become clonal very quickly. So within about 10 days, about 25% of that population are made up of either 1 to 10 clones, and after 3 weeks, about half the cells are from a single clone. And when you look at those cells and you ask the question, what are these cells actually doing? These are Tisney plots that you can see here, and it's these areas that I'm highlighting here which become activated when you show them DCs that have been pulsed with lysate. You can identify 3 populations. There's a small population down here of central memory cells that express a lot of the chemokine receptor CCR4. The bulk of this population is an effector memory cell population that secretes a lot of tumor necrosis factor, GM-CSF, interferon, and IL-4. And there's a very small population that you see here in red, which is quite similar, but is characterized by the production of IL-17, and that's a Th17 population. So when we made these cells separately, so we made a population of cells that have been stimulated with Aspergillus terreus lysate and a population of cells that have been stimulated with the Candida krusei lysate, and we mix those 1 to 1 and then ask the question, what can these cells actually recognize? Recognition being characterized by their ability to produce TNF in response to stimulation. There is reasonable cross-reactivity. So cells made in a cell population that's been made in that way will cross-react with Aspergillus fumigatus, terreus, and flavus. It will recognize Candida albicans and krusei. It will recognize Fusarium oxysporum and Solani. It will not recognize Rhizopus. To make Rhizopus-specific T cells, you have to stimulate with a Rhizopus lysate. That's another story. But it will recognize Scedosporium, and it does not recognize, using various controls, I won't go through them all with you here, but it will not recognize things like CMV or EBV peptides. And if you look at this population, it does appear that this response is mediated through HLA-DR. So it's a class 2 mediated response that comes through DR, not DP or DQ. And with the help of Dr. Romani in Perugia, we tested these in an Aspergillus mouse model, and we found somewhere between a half a log and more than 2 log reduction in the colony formation, in the fungal colony formation in the lung. You can see some of the pictures here that the animals that got T cells had much less congestion in the lungs, much lower neutrophil engagement in the lungs. And in one set of experiments in which we sectioned the brains, we found no fungal colonies in the brains at all. So on that basis, we decided to go ahead with a trial. We designed this trial we called REACT Fungal, REACT meaning reactivation post-allogeneic stem cell transplant, the 3 meaning third-party stem cell donors. This was a classical safety study, typical 3+3 design. The 3 dose levels were 1 × 10⁶ T cells per meter squared, and then 10-fold increases. And this was really a safety study, just trying to identify a maximum tolerated cell dose with the idea of once doing that, we would expand this study into a proper efficacy study. So we made these products. We used donors, and I'll show you why we chose particular donors. We put the products down. These, as I said before, these are not CAR T cells. They're not genetically modified. We put them down in a bank in cryopreserved, and the idea was to use these after allogeneic stem cell transplant. We chose donors with common HLA-DR types. You can see that in our community, there are 7 really common HLA-DR types. The commonest is HLA-DR4. So about 1/3 of donors in Australia, or 1/3 of patients in Australia, will express HLA-DR4, And just with a single product then, if you have a DR, if you make a product from a DR4 donor, you could treat a third of all patients in this way. So we made the products from those donors. We have recruited 5 patients onto the trial. 1 patient, we did not have a suitable product. This was a patient that was a DR16 homozygote. That's an unusual DR type, so we did not have a product for that patient. So we have 4 patients on the trial. I'm going to show you some data on those 4 patients and on 1 additional patient who was treated off trial, but using the same protocol. So this was our first patient. She was a 27-year-old young woman who'd had a haploidentical transplant for Philadelphia negative acute lymphoblastic leukemia. She got gut graft versus host disease that was steroid responsive about 3 weeks post-transplant. You'll see a bit of a pattern here. These patients are all sick. They all have a great deal of immune suppression. So she had troublesome viremias with CMV, EBV, HHV6, and BK, as well as BK viruria. About 4 months post-transplant, she developed pneumonia. She had a bronchoalveolar lavage that was PCR positive for CMV, EBV, HHV6, Aspergillus, Lamentaspora aurantiacum, and Clavispora lusitania. And she'd been on prophylaxis with fluconazole therapy. So this was a breakthrough infection, and she subsequently was on a variety of antifungal treatments. And I can't go through, because of time, all the details of that, but you can see them there. About a week after she got pneumonia, she developed fevers and headaches, and she was found, you can see this MRI scan here, she had a very large right frontal cerebral abscess. She was, her antibiotic and antifungal therapy was changed. The neurosurgeons got about 20 mils of pus out of this abscess, and it grew Lamentaspora aurantiacum. She was on what's thought to be effective treatment, but started to develop these additional satellite lesions and was recruited to the trial. And she received fungus-specific T cells given 5 months post-transplant, and the product was restricted by DR3. We made that product from a homozygous donor, and the patient and the donor both expressed, the stem cell donor both expressed DR3. And she had a long course in hospital. She was given antifungal therapy, so this was adjuvant treatment, if you like. But you can see over the course of several months that there was a gradual improvement and reduction in the size in this right frontal abscess. She eventually developed hydrocephalus, had to have a drain inserted. But she gradually improved, and she is now 4 years post-transplant, well without graft versus host disease, an ECOG of 0, in remission, and gone back to her job as a school teacher. So that was a very gratifying outcome. The second patient was a 62-year-old man who had a haploidentical transplant for lymphoblastic lymphoma. Again, similar story, IBMTRC, so severe skin graft versus host disease, a month post-transplant, steroid responsive, but CMV viremia, increasing dyspnea 3 months post-transplant. Here is the CT imaging pre-T cell infusion. This was a breakthrough infection on itraconazole, proved to be due to Lamentaspora prolificans this time, had fungus-specific T cells 4 months post-transplant. These were restricted through DR15 and had a very rapid improvement. He did develop severe chronic graft versus host disease post-T cell infusion. I'll come back to that in a later slide, but is currently very well 3 years post-transplant off all therapy without graft versus host disease. And the final patient on this first dose level was a 69-year-old male who'd had a haploidentical transplant for follicular lymphoma. About day 15, he had this mass that you can see here in his right lower lobe, scattered nodules elsewhere. A lavage was positive for CMV, HHV6, and Aspergillus. He had some fluid that was positive for galactomannan. He had positive blood galactomannan, as you can see shown here, and the bronchial washing showed fungal elements. He had concurrent viremias, as you can see on the slide, Again, a breakthrough infection on fluconazole, for which he was switched to voriconazole. Again, was given fungal T cells a month post-transplant. Patient, donor product, all DR3 restricted. And he had quite a rapid response. You can see that the nodule reasonably rapidly resolved, although he did get some hazing in other areas of his lung. He developed a graft versus host disease. After the T cell infusion, it required treatment only with topical therapy, and he improved quite considerably to the point where he was discharged 2 months after transplant, but was readmitted a month later, and he actually died 4 months post-transplant with disseminated Mycobacterium avium intracellulare. None of the first 3 patients had infusion-related reactions, and they were all considered to be, in terms of safety, to be satisfactory, and we escalated to the next dose level. And the 4th patient has received cells on dose level 1. Similar story, 71-year-old man, multiple viremias, a month post-transplant. You can see these nodular densities in his lung. The lavage showed isolated fungal elements. His was a breakthrough infection on voriconazole, and he was subsequently treated with voriconazole and mycofungin. We infused a product that was restricted by DR7 on this occasion, and he had a very rapid improvement in his imaging and clinical picture, and he was discharged in follow-up. He's very well. He has very mild oral graft versus host disease, no infusion reactions. So the last patient I referred to earlier, an interesting young man who came to transplant at our center with known myeloid sarcomas and prior CNS involvement. Prior to his transplant, he'd had probable invasive fungal infections in his lung, but he had refused biopsy. And although that had been strongly recommended to him, he decided that he was not going to have a biopsy, and he just wanted to proceed to the transplant, which was eventually done because it was thought that his risk was so great. And he went on to the transplant, and within 3 weeks, he had fevers, blurred vision, and a left-sided ptosis. You can see on this MRI scan that he had a ring-enhancing lesion in the left caudate nucleus. Not shown is one that he also had in the right frontal region. He was offered the trial, but he decided not to be involved in the trial, declined involvement. He had a lavage that flew Klebsiella and was positive by PCR for Candida albicans. And despite treatment, on imaging, these lesions progressed, and he ultimately agreed to have fungus-specific T cells off trial. He had 2 infusions at 2 months, and then at nearly 3 months post-transplant, these infusions were restricted through HLA-DR15. There was a great deal of concern by our ID physicians and neurosurgeons about him. 3 weeks after his second infusion, he had apparent progression with a left caudate biopsy, which showed a perivascular lymphoid infiltrate, and that PCR was positive for Naganitia. And then a week later, due to further progression, he had another caudate biopsy, which showed a lymphohistiocytic inflammation within the parenchyma and in a perivascular distribution, and a single focus of fungal hyphae. The situation continued to evolve, and about 8 weeks after his second infusion, he had a neurosurgical procedure with a septal pellucidotomy. And during that procedure, they cleared ventricular debris, which showed an inflammatory infiltrate. There were some fungal elements with branching hyphae and some cryptococcus-like organisms. Again, the Candida albicans PCR was positive, and it was concluded on the basis of all the information that he probably had a mixed yeast and mold infection. So here's the sequence of his imaging on top. So each of these is a T1 and a T2 weighted image. You can see 2 days prior to his first infusion, he had this left caudate, this left caudate lesion and significant edema around it. The second set of images is about a month after the second infusion. He now has a more significant edema and progression. A month after that, he now has a significant ventriculitis with quite a lot of edema. And then about 4 months after the second infusion, he now has hydrocephalus, a drain inserted. But some, at least, of this inflammation seems to have gone, and maybe the edema is resolving. And about 5 months post-transplant, he was discharged. He'd improved. This is a year after his second infusion. He's now well a little over 2 years post-transplant, fully active with no graft versus host disease. So look, just a quick comment on the graft versus host disease. The first 2 patients had graft versus host disease prior to the T-cell infusion. The second patient had chronic graft versus host disease post-infusion. Is the only patient that required systemic immune suppression. That patient is now off all immune suppression with no chronic GVHD. The second 2 patients on the trial had no graft versus host disease before their infusion, but patient number 3 got moderate chronic GVHD of the skin and liver, treated just with topical therapy, and that has now resolved. That patient died of atypical mycobacteria, and patient number 4 has only very mild chronic graft versus host disease. He wasn't even aware of it and he's not on any therapy. In terms of just quickly showing you some of the correlative science on the first 2 patients, what we saw here was an increase in the T cells peripheral T cells, starting at about a month post-transplant. So we did see an increase in T cells. That increase in T cells consists principally of activated CD8 positive T cells. We did see in both of the first 2 patients quite a rapid reduction in the expression of a TIM3, which is an inhibitory subset. So that subset seems to disappear very quickly within 3 or 4 days of the fungus-specific T cell infusion. We saw a bump in NK cells in one of the patients in particular, about a month post-transplant, and an increase in traditional monocytes starting about 2 weeks post-infusion. And a really dominant finding in both of the first 2 patients was the appearance in the serum of quite high levels of RANTES and slightly lower levels of another chemokine called MIP1 beta. And these are chemokines which attract monocytes and T cells and draw them towards inflammatory areas. We looked for evidence by ELISpot of the ability of circulating lymphocytes to respond to fungal antigens. And in one of the patients, we were able to show, starting at about 2 weeks post-T-cell infusion, that the lymphocytes in the blood were able to recognize fungal antigens and respond to those fungal antigens by the secretion of TNF. And that was restricted by DR15, which was the restricting DR of the product that we had infused. Now, D. Dilupati in our lab has taken this work a little bit further. I'm not going to go through this in any detail at all, except to say that using the products that we've created, D is now isolating fungus-specific T-cell receptors. We have isolated 6 T-cell receptors against Aspergillus terreus, 4 against Candida krusei. You can see the HLA restrictions there. And in my last slide here, I'm just going to show you a little bit of that activity. So looking at this bottom right here, we are creating T cells that now have artificial receptors. These are transgenic T cells that have a native receptor, an endogenous T cell receptor, and we have inserted into that T cell receptor a transgenic fungal T cell receptor, and we are stimulating those cells now with homozygous, HLA-DR homozygous lymphoblastoid cell lines. So here, if we take a DR1 restricted Aspergillus transgenic TCR, so we have that population of T cells that now contain this TCR, we stimulate them with our lymphoblastoid cell line, which has homozygous DR101, and we can see that about a quarter of those cells will produce TNF. If we do the same thing, but we change the DR to 1001 or to 1501, we get no response. If we use DR101, but we block DP and DQ, that has no effect. If we use the lysate only, but we have no DR1 present, we get no effect, and control cells show nothing. So here we've transferred an Aspergillus T cell receptor into another T cell and made it functional. And so let me sum up here. What I hope I've shown you is that T cells can be efficiently expanded in vitro following exposure to water-soluble fungal lysates, and that can be done without any genetic modification. We don't need to make CAR T cells. Those cells are mainly CD4 positive. They produce Th1, Th2, and Th cytokines. I didn't show you the fungal hyphal killing data, but we have shown that they will kill fungal hyphae in vitro. We have started a phase 1 dose escalation study of third-party fungus-specific T cells for fungal infections, and we've treated 4 patients on the trial. 3 of them have had graft versus host disease post-infusion, but in all cases, the graft versus host disease has resolved satisfactorily. 4 of the 5 patients, 1 off the trial, have cleared fungal infections, and 3 of those infections have been lung only, 2 have been CNS and lung, and 4 of those patients are alive with ECOGs of 0 to 1. And we have cloned fungus-specific T cell receptors, and those are functional when expressed in normal T cells, raising the possibility that we might be able to make transgenic TCR-bearing T cells as a therapy in this disease. So I'm going to stop there. I just want to quickly acknowledge our funders, particularly the Cancer Council of New South Wales and the Susan and John Freeman grant that we received. I want to thank various people, particularly Gaurav Sutrav and Dee Dulapati, who've done a lot of work on this, my colleagues Leighton Clancy and Ken Micklethwaite, our T-cell manufacturing team, my colleagues in the transplant program, the various people involved in assisting with the trial, and of course our patients and nursing staff. And with that, Monica, I will stop and happy later on to answer any questions.
Thank you so much, David. And what an amazing talk, and what amazing responses that you've shown us in some very notoriously difficult fungal infections. So really promising data and very nicely justified with all the testing that you've done. So we'll move on now to hear from Pedro Puerta-Alcade, who's from the Hospital Clinic of Barcelona. And Pedro spent 6 months visiting NCIC in 2023, where he conducted the largest study of C. difficile in cancer. But he's also an emerging research leader in bacterial and fungal infections. And he has been working on a fungal CAR T cell program for some time. And we heard about it when he visited us in 2023, but we will get an update on it today. He will be talking to us about his fungal CAR T cells. So over to you, Pedro.
Good morning, everyone. I am Pedro Puerta from Hospital Clinic in Barcelona. First of all, I would like to thank the organizers for inviting me to be here. And it's such a great honor for me, and especially when I am surrounded of such great speakers. So it's such a shame that I cannot be there in person, but I will be glad to share any opinions after the talk. So these are my disclosures. And first of all, let me start with a very brief introduction, because we all know that there are many new hosts that are susceptible to fungal infection, and also there is an increase in fungal infections caused by rare and multi-drug resistant fungi that are associated with very high mortality, especially because of these breakthrough fungal infections. And we also know that current antifungals are associated with significant toxicities, cost, and significant drug-drug interactions. And also, it is well known that the clinical efficacy of these antifungals is suboptimal or even null if the immunity is not restored. And that's why an appealing response to these challenges would be the use of adoptive cell transfer. That could be specifically the use of specific T-cell infusion or the use of chimeric antigen receptor therapy. And very briefly, because Dr. Gottlieb probably explained this before, but with the specific T-cell infusion, basically we perform leukophoresis to obtain the T cells, and then we have some specific T cells that we identify based on the response to the fungal antigen, usually this lysate of Aspergillus components, and based on the Th1 response we select those cells that are specific, and then we expand them ex vivo through cytokine stimulus and infuse them back to the patient. The other potential alternative would be the use of CAR T cell therapies. So the chimeric antigen receptor therapy at the beginning of the process is similar. We perform this leukophoresis, then we obtain the T cells and we enrich them and activate them, and then we basically make them express a chimeric antigen receptor in their surface. We could do that with a lentivirus transfection, or also with a transposon-based procedure. And then when the T cell or the cell expresses the CAR in the membrane, we expand these cells and then we infuse them back to the patient. And then the CAR cells attack their antigen in the picture. They attack the CD19 B cells. And if we look into more detail, then we can see here the structure of the chimeric antigen receptor. We can see it has this extracellular part, that's the part that recognizes specifically the antigen, and then the intracellular or transmembrane part, that's the part that transduces the signal. No? When it recognizes the antigen, then it produces an effect. And if you see the image, this chimeric antigen receptor, the extracellular part, is basically formed by the single chain viral fragment of a monoclonal antibody. That's the part that's specific, and then this part is attached to the T cell receptor. And then there have been some different generation of CARs. And basically the difference between them is that they have added these co-stimulatory domains that what they do is that they enhance the response once the receptor finds the targeted antigen, and they also prolong the half-life of these cells. And what's the good thing of this CAR therapy compared to specific T lymphocytes? So the CAR T is not HLA restricted. The lymphocyte at the end needs another cell to present the antigen, a macrophage or the dendritic cell to present the antigen, and in this case you don't need it because it goes directly to the specific antigen. And this makes also that the target cells have limited immunizing capacity to evade the detection. And as you are using these monoclonal antibodies, you can direct the CAR conceptually to multiple and to any antigen. And this is a work from the people from Houston and Dr. Kontoyiannis also. You can see here in the left-hand side of the image, you can see what's a T cell receptor, and then in the figure C, you can see a classical CD19 receptor CAR that's formed with the single chain viral fragment of this monoclonal antibody against CD19, and this is attached here to this CD28 and then CD3 delta of this transmembrane and intracellular part of the T cell receptor. And what they do is quite an amazing thing, that they decided to attach this extracellular part of the Dectin-1 instead of using the single chain viral fragment of a monoclonal antibody. And what is the Dectin-1? So the Dectin-1 is C-type lectin receptor that specifically recognizes and binds beta-D-glucan. And so they thought, okay, if we use this extracellular part of the lectin-1, then it will recognize the antigen, will transmit the information to the intracellular part, and the T cell will make the response and try to kill the pathogen. And to see this, they performed this amazing experiment. This is a Cooper lab experiment, and basically they have these spores with immunofluorescence, and they put it in a plate, and they perform a video time lapse during 24 hours, and then afterwards they reproduce it in an ultra fast way. And we can see here the first experiment, how the spore starts to grow, and then the hyphae here starting growing nicely because there are no cells in the plate. And then the second part of the experiment, we have also the same experiment, but then they infuse the CD19 CAR cells. And of course, you see a lot of cells going around because you have infused the cells, but as they don't direct to this target, they don't bind to the hyphae here, and the hyphae can grow equally. But in the last part of the experiment, they do the same experiment, but in this case, they infuse the lectin-1 CAR. And in this case, you can see very, very nicely how, as the spore starts to grow, millions of these lectin-1 CAR cells come to the place and bind to the initial hyphae here and kill the hyphae and not let them grow, basically. A very, very nice experiment. But the problem here is that they realize that the lectin-1 binds with very high affinity to the spore and the early germlins, but the affinity is significantly reduced to the mature hyphae. That's why this same group of Dr. Kontoyiannis and the people from MD Anderson in Houston have been working in this another construct of Aspergillus fumigatus CAR. They just published this recently, a few months ago, and using this monoclonal antibody that binds specifically to several species of Aspergillus, but not to, for example, to Mucorales, or also not to commensal yeast. And they use this single chain variable fragment of this monoclonal antibody that is attached here to this transmembrane domain, and then to this co-stimulatory domain 41BB that enhances the activity and prolongs also the half-life and reduces potentially the immunotoxicity. So they also perform this nice thing of tagging the CAR with a green fluorescence protein. So you can see here in these early experiments how the CAR binds to this mature hyphae here and forms this kind of clusters around the mature hyphae and inhibiting the growth of the hyphae. And then you can see here they use these 3 different cytokine regimens, and with all the regimens to expand the CAR cells, and with all the regimens there was a significantly reduced hyphal length, and also reduce of the branching of the hyphae. And also very nicely they perform a new experiment using in this case the minimum effective concentration of caspofungin, and the effect of the CAR still persisted with the caspofungin. So you can see clear here reduction in hyphal length and the colony area of Aspergillus when added to caspofungin, and actually the response was higher compared with no caspofungin at all. So it seems that the caspofungin and the CAR cells could be synergic, maybe because caspofungin helps expressing or seeing some of the components of the Aspergillus cell wall. And then finally, they performed this experiment with an NSG mice that additionally was immunosuppressed with cyclophosphamide, and then they saw that clearly they used this murine sepsis score, and those mice treated with Aspergillus fumigatus CAR had reduced murine sepsis score, and very nicely here at 7 days, 11 out of 12 mice treated with control cells died, and only half of the mice treated with the Aspergillus fumigatus CAR died. And more importantly, of those mice that survived, 5 of 6 had stable disease according to this murine sepsis score. So the Aspergillus fumigatus CAR was able to stop mortality and actually to stop the progression of the disease. And also, this is another work. This is a German group also working in this concept of antifungal CAR. They use this transposon-based procedure for the expression of the CAR, and in this case they use also the single-chain variable fragment of a monoclonal antibody. In this case, this AB90E8 that specifically targets Aspergillus fumigatus with no reactivity to other Aspergillus species or also to other fungal species. And you can see here also very nicely how this Aspergillus fumigatus CAR also binds to mature hyphae here and also form these kind of clusters, inhibiting the growth of the cells. Also in the B panel, you can see that it binds specifically to Aspergillus fumigatus, but not other species of Aspergillus. And in the panel D, you can see the secretion of perforin, granzymes also. And finally, in panel E at the bottom, you can see that the binding produces also a clear hyphal damage. So it seems to be clearly effective in vitro. And then they also perform this neutropenic mouse model here, and you can see here in the panel B how clearly those mice that were untreated or treated with the control CAR had significant mortality, 60-70% mortality compared to only 20% mortality of those mice treated with the Aspergillus fumigatus CAR, and also the animals had retained body weight and the Aspergillus fumigatus CAR, and this was mediated through the secretion of different cytokines and granzymes also. And finally, they perform these lung biopsies, and you can see clear in the left-hand side and in the middle how those mice treated with not treated or with control CAR in the lung biopsy had several of these hyphae growing around, and in those mice treated with Aspergillus fumigatus CAR, they don't have hyphae at all and only a few spores. So it seems to work, at least in this animal model. So with all this in mind, we have been working for many years, and immunologists from our hospital have been working for many years in this CD5 receptor, and this is a pattern recognition receptor that's expressed mainly in T lymphocytes and also in some B lymphocytes and dendritic cells. And similar to Dectin-1, the main ligand of this CD5 receptor is the beta-glucan. And some experiments before from our group show that this soluble form of CD5 binds to fungal species through recognition of beta-glucan, and actually the constant of dissociation of this beta-glucan is very similar to that of Dectin-1, and when it binds to the beta-glucan, it produces intracellular signaling and cytokine release. So also it has been shown that CD5 deficient mice are more susceptible to invasive fungal disease, and actually there are some animal models showing that the infusion of a soluble form of this CD5 reduces mortality in infectious and in fungal infection models. So similar to the people from Houston, we took advantage of this natural CD5 receptor, and we used the extracellular part, the part that binds to the antigen of the CD5, and then attach it to a common CAR construct of this CD8 alpha and then 41BB and then CD3 delta. And then the main difference is that we are using NK cells. And why NK? So the good thing from NK is that they don't have alloreactivity, so the risk of GvHD is minimal. We all know that the NK cells have high cytotoxic capacity. They secrete these perforins and granzymes, and they induce apoptosis. They also can stimulate other actors of the immune response by secretion of interferon gamma, TNF alpha, and other cytokines. And actually the NK cells themselves have shown to be effective in animal models of fungal infection, also without CAR expression. So yeah, very appealing, and of course not so much as the T lymphocyte, but NK cells also have some immunological memory. And with all this in mind, we had this patient who had acute myeloid leukemia and then had a disseminated fungal infection caused by Fusarium petroliphyllum, a member of the Solani family, and then the antifungogram showed that it was virtually resistant to all available antifungals, and he had no option, and very bad prognosis. And then we were happy to obtain the compassionate use approval of the Spanish agency for the use of the CD5 CAR, but in this case expressed in NK92 cells. So the NK92 is a leukemic lineage of NK cells that is mainly used for research, and we had this construct with the CD5 CAR expressed in these NK92 cells. So in just a few days we were able to obtain a huge number of cells, so we could use it for the therapy. And then we had to irradiate them because this was a leukemic lineage, and then after irradiation we infuse it in an increasing dose over these 3 weeks. The problem is that while we were using this therapy, the hematological malignancy progressed, the patient started having a lot of blasts in periphery, so it has no sense to continue with the therapy, and comfort was prioritized, and the patient unfortunately finally died. And regarding clinical assessment, it was difficult because patient was having fever since the admission and continued having fever all the admission, and then the chest CT showed dissociated evolution. Some of the lesions improved, and then some others worsen, and the same happened with the skin lesion. So it was difficult to say if the therapy worked or not, but for sure it was well tolerated, and no major issues were actually seen. So as I said, these NK92 cells have the potential of inducing a secondary leukemia, and that's why we have been afterwards working on cordon blood NK cells. And these are some experiments here: Candida albicans, crypto, using this CD5 CAR with cordon blood NK cells. And you can see here how it's clearly effective. It has killing, increased killing compared to untransfused NK cells. And these cells were also effective in models of Candida auris, Aspergillus fumigatus, or Fusarium solani. And also we performed this animal model here, and you can see also here Candida albicans, crypto, how these CD5 CAR cells, NK cells, were effective in reducing mortality in Candida albicans and crypto, and also in the kidney and lung biopsy it reduced the fungal burden, and although it's not shown here, it was mediated through increased markers of cytotoxicity and interferon gamma. So with all this in mind, we were happy to obtain the funding for this academic clinical trial funded by the Spanish government and also the European Union to conduct a phase 1 clinical trial with the use of these CD5 CAR NK cells for invasive mold disease. So we're planning to conduct this phase 1 open label, prospective, single center and non-randomized clinical trial, basically to assess mainly the safety, but also, if possible, the efficacy of these CD5 CAR NK cells. And we're planning to have 10 patients with refractory fungal infections in approximately 3 years of recruitment. And of course, we all know that it's not possible to use this therapy nowadays with every fungal infection. So that's why we try to define a very severe prognosis population. And basically, we had this definition here: patient that after a week of treatment has increasing biomarkers of fungal infection, or persistent positive cultures, or biological worsening after a couple of weeks, or also, like the case of our patient, clinical worsening and culture showing resistance to all available antifungals. And based on the literature, we think that these patients have around 80% mortality. But one of the most important things is that once you have this kind of patient or this kind of infections, you don't have the time to prepare this therapy, because you may need around 2-3 weeks of time to prepare the therapy. And that's why we have been working in this therapy production that we show you here. As I told you, we are obtaining the NK cells directly from a donor cord blood, and then we separate and enrich and activate the NK cells, and then we have to make them express the CAR receptor. And we are doing all this procedure of separating, enriching, and activating the cells and make them and transducing with this CD5 CAR in a closed GMP process using this Clinimax Prodigy machinery from Miltenyi. This is a biotechnology firm from Germany, and then somehow you got the final process of the cells. Of course, this had a lot of work to optimize the process and obtain the maximum number of cells and expression of the CAR, but we are very close now. And then once you have the cells, we plan to freeze them and then unfreeze them once you have the patient with the inclusion criteria, and then using it as off-the-shelf therapy. And ideally, we hope that it will join the fungal cells and exert the activity. But of course, there are some major unsolved questions regarding this therapy. First, CRS and ICANS are potential risks following this CAR therapy, although we think that maybe the risk is somehow lower than with T lymphocytes. Of course, the impact on Candida and other commensal yeast may influence both toxicity and efficacy of the cells. We don't know about the optimal dosing for these therapies, either CAR-NK or CAR T cells. We are using now what's being used in the clinical trials with CAR-NK cells, although these trials are mainly in cancer patients. And then maybe there is a need for synergy with other antifungal therapies like cytokines or immune checkpoint inhibitors, but this is an area for research in the future. And of course, the widespread application of this therapy is limited by the high cost, no? Because this is a very expensive therapy to produce. But however, we think that this off-the-shelf therapy may enhance the prognosis of selected patients. So that's all. Thank you so much for your attention. And of course, again, sorry for not being able to be there and not being able to answer any questions, but here is my email, and I'd be pleased to have any conversation with any of you if you want to. Thank you so much.
Thank you, Pedro. And what a fantastic overview there of a really exciting technology. And we look forward to hearing about the outcome of the clinical trials. So we might move on now to our next speaker, who is Dr. Julian Lindsay. And Julian is an academic pharmacist who's now working at the Fred Hutchinson Center in Seattle, USA. Julian completed his PhD at NCIC in 2023 and was awarded the Dean's Award for Excellence. He's now leading a pharmacogenomic multi-center study across USA and Australia, based at University of Queensland, and he will be assessing the role of pharmacogenomics and modelling in voriconazole therapy. So very relevant to what he's going to talk to us about today. Over to you, Julian, now.
Hi, my name is Julian Lindsay. I'm a clinical research pharmacist at the Fred Hutch in Seattle, USA. And today I'm going to be discussing pharmacogenomics to optimize antifungal therapy. So in today's discussion, I want to go over the background of pharmacogenomics, discuss how we can incorporate pharmacogenomics into antifungal therapies, how to implement a pharmacogenomic service, and then the future directions in this field. So first of all, a little background into pharmacogenomics. So essentially, pharmacogenomics is a field of research that studies how a person's genes affect how they respond to medications. This is largely liver enzymes that metabolize drugs, and this is mostly the cytochrome P450 system, looking at genes such as enzymes such as CYP2D6, which converts codeine to morphine, or CYP2C19, which we're going to discuss further today, which converts the active voriconazole into the inactive voriconazole N-oxide. So essentially what we look for in pharmacogenomics is variants or polymorphisms, which are usually denoted as a single nucleotide polymorphism, or SNP, in a person's genes. And this is largely denoted as a star system. So the two copies is usually *1, *1. So that would be the wild type. It could be *1/*2. So this would be heterozygous wild type. And a great visualization of this that I like is a very famous SNP polymorphism in the native Australian Gouldian finch affects the phenotype or the color of their face, in that the wild type has a black face, the homozygous mutant SNP is an orange face, and the heterozygous SNP is a red face. And it's exactly the same way for the CYP enzymes. So essentially what we're looking at in these enzymes, the phenotypes are often called poor metabolizers, regular metabolizers, or ultra-rapid metabolizers. And this field is closely monitored by the FDA, and currently over 200 medications have pharmacogenomic advice in drug labels. So how do I test for the pharmacogenomics of these enzymes? Essentially, there are a couple of different ways to do it. You can use next-gen sequencing, but the most common form is a real-time PCR after DNA extraction, and that can give you an array, a full panel of different genes that are assessed. Now, the PCR test itself is quite rapid, 24 to 48 hour turnaround time, but if you're doing that for an individual patient basis, that's very expensive. If you're sending away this test, it could be much cheaper due to batching, but you might not get the result for a week or 2 weeks. And this is really important when you're thinking about what you're using it for and you're implementing the service. You can use pretty much any form of DNA, blood, saliva, or swab, but especially in our patient group, you have to remember that you cannot test the blood and even the saliva of an allogeneic stem cell transplant patient or a liver patient, because you'll only be testing the genotype of the donor, which isn't going to tell you much information. If you do have an allogeneic patient, you would need to find pre-transplant DNA for that. So how to interpret the results? A very good resource is the Clinical Pharmacogenetics Implementation Consortium, or CPIC, and this gives a great guideline into a number of different enzymes. And as we're talking about CYP2C19 today, I've brought up their example of the phenotypes and genotypes. So you can see that it has ultra-rapid metabolizers in which the 2 to 5% of the population exhibit, and this is that star 1717, so homozygous star 17. Rapid metabolizers, 2 to 30% of patients, and this is that heterozygous star 1, star 17. About 50% of patients are normal metabolizers or intermediate metabolizers. And then there are genotypes for poor metabolizers, so 2 to 15% of population. And the reason for that large variation, especially for the rapid metabolizer group, is because of ethnic and race diversity. So a lot of patients with Asian background are much more common to have to carry the gene to be a rapid metabolizer. And we don't really have time to get into the details of it, but this actually may explain a lot of the results from international trials where there isn't much ethnic diversity. So that's something to sort of keep in mind when looking at voriconazole and CYP2C19. So then when we have the type of genotype for the different enzyme, we have to think about what that enzyme does. The first and most common enzyme that's tested is CYP2D6, and this was originally tested because it's the enzyme that converts codeine into the active morphine. And so people that are poor metabolizers of 2D6 will actually have very low levels of the active morphine circulating, whereas ultra-rapid metabolizers are going to have higher levels of morphine. So these are the patients where they have some codeine and they have a lot of effect and side effects from that medication. Where on the other hand, CYP2C19 converts the active voriconazole into inactive. And so your ultra-rapid metabolizers and rapid metabolizers are going to have very low levels of voriconazole. And poor metabolizers are those that are going to have very high levels and a higher risk of toxicity. So how to then use this information to guide clinical practice? So going back to the CPIC guidelines, it does give some advice for therapeutic recommendations, but it's very vague. There's often broad statements, for example, rapid, ultra-rapid metabolizers, recommending to just change to alternate therapies, and same with poor metabolizer. However, in practice, sometimes we really know that voriconazole is the best drug, and is there ways that we can get around this? So like I said, there's a lot of guidelines in CPIC. There's 26 guidelines for 22 different genes. And you can see here CYP2C19 is very relevant for voriconazole. And then there's a few other ones we're going to talk about later today, like 3A5 and UGT. But you can note that CYP3A4, the most common of the cytochrome P450 enzymes, is not there. And that's because 3A4 actually has, essentially there is some genetic diversity, but the phenotypes aren't too diverse, which means even if there are differences in people's genotypes of 3A4, it doesn't really correlate clinically to any relevant ways to implement different 3A4 genotypes. And so, unfortunately, our workhorse and most common enzyme in antifungals cannot be used. So, taking a little step back to common antifungal agent metabolisms, when thinking about how to use pharmacogenomics in antifungal agents, we want to think about what the pharmacokinetic properties of the agents are. Is there inter-individual variability? If there's a drug that's out there and there's no variability, then it doesn't really make much sense to look at people's different genes. Is there clinically relevant pharmacogenes that have been established in that group? And is there evidence for their associations of safety and effectiveness in antifungals? So I've listed a few of the most common antifungal agents here, and I don't have time to go through all of them. You can see that a lot are CYP3A4, as most people here would know, and that the quinacandidins aren't really, they're mostly metabolized unchanged. But you can see a few things standing out. One, voriconazole, as we've discussed, and if you've if you've worked with pharmacogenomics before, it's the main antifungal, which is a major metabolite of CYP2C19, which has a large amount of evidence for the use and a lot of diversity in the population. So it's a really great target. Some other medication which there may be used for pharmacogenomics, isavuconazole is partially metabolized by CYP3A5 and UGT. Posaconazole also undergoes UGT glucuronidation. So, as we've said, voriconazole is the perfect candidate for pharmacogenomic implementation. It's predominantly metabolized by CYP2C19, and CYP2C19 itself is saturable, which means if you get to a point where the enzyme is saturated, then you start seeing huge spikes in the level of voriconazole. And because there is a narrow therapeutic index, you then see toxic side effects in a lot of patients. There is also a lot of evidence that subtherapeutic levels lead to poor response or poor prophylaxis. And there is good evidence that using pharmacogenomics of CYP2C19 can improve voriconazole levels. So we have a CYP enzyme that we want to look at. We have a drug where there's use for that. How do we implement a service? And so the considerations for a pharmacogenomic service are, what are the aims going to be? And this is really going to dictate how you send away different assays and how you're going to implement that. So do we want to achieve therapeutic levels more rapidly? Do we just want to avoid toxicity, reduce medication cost, or maximize therapeutic effect, or all of the above? And then what's the time frame of therapy and testing? And this is really important for voriconazole because are we looking at prophylaxis where we know we're going to use voriconazole because that's the standard? Or do we have a patient that currently has a very severe fusarium infection and we are starting voriconazole and we want to get therapeutic levels as rapidly as possible? And then again, and that's relevant to what context is this agent being used. So there's a lot of evidence out there of CYP2C19 guided voriconazole doses. But if you look through it, a lot of it is in prophylaxis, or it's retrospectively looking at patients' pharmacogenes and seeing associations. There's actually very little evidence to guide prospective use where you're starting voriconazole and you don't have their pharmacogenomics details. One of the most standout publications recently is by Patel et al. And this was a transplant group where they knew they were starting voriconazole for prophylaxis. So in the transplant workup, they could send away, test CYP2C19, come up with a higher dose for those rapid and ultra-rapid metabolizers and start them at a higher dose. And they did find a reduction in subtherapeutic levels, from the historical control of 50% at first level to 30% using the genotype guided cohort. And then looking at just the rapid and ultra rapid metabolizers, 70% of the historic control had subtherapeutic levels, and that was reduced using the genotype dose to 15%. So there's good evidence that increasing the dose for those rapid metabolizers does lead to more effective level attainment. But like I said, what about those patients where you want that level quickly and you don't have time to send away for that test? And this is where we really want to implement the use of pharmacogenomic testing at the Fred Hutch. We don't necessarily use prophylaxis routinely, use voriconazole for prophylaxis routinely, and especially when we want therapeutic levels, it's usually for directed therapy when we have a fungal organism where we know voriconazole is the best agent. So we really wanted, so we were able to work with the lab to develop an assay in-house so we could get that result rapidly. And we wanted to know the clinical characteristics of the patients that were getting these genotypes, the turnaround time using our internal lab, and what were the dose adjustments and therapeutic levels we attained. Essentially, this is a flowchart of when voriconazole initiated. Essentially, the only difference, we still did normal loading and maintenance dosing up front and a standard level ordered within 5 to 7 days. But we also, at that time, ordered CYP2C19 testing. And then when that was returned, the Antimicrobial Stewardship Service gave advice as to any dose adjustments for that patient. So, like I said, the CPIC therapeutic, this is very busy, you don't have to read all of it, but the CPIC therapeutic recommendations were very vague. So we had a look back at previous doses for different phenotypes and essentially came up with, based on the literature, increased doses so that a rapid or ultra rapid metabolizer would be increased to 5 to 6 milligrams per kilogram every 12 hours rather than the standard 4. Half dosing for poor metabolizers. And in patients where we would normally have a subtherapeutic level and we would increase by increments of 50 milligram per dose, we would increase more rapidly at 100 milligram per dose. Another strategy that is used in practice, but there's not too much literature on it, is in these rapid metabolizers, instead of BD dosing, you can divide the daily dose into 3 times a day dosing to try and make up for that rapid metabolism. I do note, though, you have to be careful with these high doses because even though the person is clearing voriconazole rapidly, they're still accumulating a fluoride at the same rate of anyone having the voriconazole tablets. And so for long-term use of these higher doses, you can very commonly see hyperfluorosis and the problems associated with that. So these results are preliminary, but essentially over an 18-month period, we initiated voriconazole in 234 patients, and the rollout or the pilot was required for selected patients. So we definitely weren't able to give this to everyone. A lot of logistics were involved, but about 10% of patients started on voriconazole. We implemented 2C19 testing. The turnaround time, by the time voriconazole was initiated and we wanted to order the test to when we got the test back and valid and reported, was 4.3 days. It was about 3 to 5 days depending on whether it was a weekend day or not. And then that dose change usually happened within the next 24 hours. Now, in this very selected population, there were about 30% of patients that had actionable phenotypes. So we had an ultra rapid metabolizer, 6 rapid metabolizers, a lot of normal metabolizers as you'd expect, and 1 poor metabolizer. Now, as an example, when this was really useful for us, we had, and this might be a common scenario for a lot of people with patients that transplant or see AML patients, 46-year-old male, AML, large fellow, 112 kilos, and this man had probable invasive pulmonary aspergillosis with nodules and galactomannan positive, and also a presumed fungal CNS infection. So we wanted to have therapeutic vori levels pretty rapidly. We started 300 milligrams BD, had 2 subtherapeutic levels. We increased to 400 milligrams BD, And this was when we just had the test available and we ran the CYP2C19 test, which came back as a rapid metabolizer. And this meant that we could sort of be confident to increase that dose to 350 TID. And that was what it was required to get that level up above 1.5. Now, that was one example of a selected patient where it was really useful. Looking at all the patients where we tested, there was a lot of these patients. There was, so the light blue line is when we did the CYP2C19 test, and the orange line is voriconazole levels. There were examples where there were poor metabolizers that had very high levels, and we reduced that dose right down and got down to therapeutic levels. We had patients where there were sub-therapeutic levels where we were able to achieve therapeutic levels, but there was a lot of patients, especially starting initially, where they were normal metabolizers and their first level was in the range. And this, essentially, in certain patients, it was extremely useful, but the actual utility of testing everyone, it sort of raised more questions than answers for us. And this leads us on to a randomized control study that we're putting together, which should be together soon. It's a large multi-site study called the Pragmatic Study. And this is an Australian-led MRFF-funded randomized control trial, which is actually going to answer, hopefully, some of these questions using CYP2C19 testing upfront versus standard of care dosing. And this should really tell us the benefit in upfront testing for all voriconazole patients. We can see how many patients we need to treat for benefit. There is health economic portion to it, and we're actually comparing it to Bayesian modeling as well. I think this is will be really good evidence and what we need to get that body of evidence for pharmacogenomic testing, so that hopefully in 5-10 years time, every person that walks into a hospital just gets their full cytochrome P450 enzyme panel tested, and all of the drugs where this research has been done, we can dose accordingly. So what about other antifungals? Can we use this for any other antifungal drugs? Posaconazole, not really. There's been one single study in the old oral suspension that uses that tests UGT1A4*3, and this did show that a polymorphism was an independent risk factor for poor absorption. Itraconazole, ibrexafungerp, and alorifim. It's unlikely, as these are majoritively CYP3A4 polymorphisms. However, the exact cytochrome P450 enzymes that metabolize olorifilm I couldn't find a lot of solid literature on if it is only 3A4. So there's potential, as there's more research comes out in olorifilm, that we potentially could use pharmacogenomics. Isavuconazole, on the other hand, is metabolized by 3A5 and UGT, and so there's potential for future research in isavuconazole research as well. But at the moment, there's not too much else. So in summary and take-home messages, pharmacogenomics is established precision medicine strategy for numerous drugs. And I'd refer you to the CPIC guidelines to examine what evidence there is for which enzymes and which drugs. Voriconazole is currently the only antifungal with a really clear benefit to use pharmacogenomics. However, in selected voriconazole patients, CYP2C19 can be an excellent tool to incorporate in current clinical care. But I think further research is warranted, and hopefully coming with the Pragmatic Study, for the specific place in therapy for which patients should be getting it and when we should be testing, and then specific dose adjustments and health economics of pharmacogenomics for voriconazole. So thank you very much. I'm really sorry I can't be there in person. I would have loved to be, but any questions or comments at all, please email me at jlindsay@fredhutch.org. Thank you very much, and I hope the rest of the symposium goes well.
Thank you so much, Julian, and really look forward to seeing the results of that excellent trial. We'll move on now to our very final speaker, last but not least is Dr. Shivani Pasricha, who's a laboratory head in the Department of Infectious Diseases, University of Melbourne at the Peter Doherty Institute, and a current collaborator at NCIC. She completed her PhD in fungal genetics and pathogenicity, and she's got a current interest in diagnostics, particularly CRISPR diagnostics. Her work on this has been published in Lancet Microbe, and she's currently working on a fungal diagnostic project. So over to you, Shivani.
Hi, everyone. Thank you for the opportunity to present today. I'm actually really excited to share with you this, I guess, a bit left of field for today, work we do with CRISPR diagnostics. I'd like to begin by acknowledging that today's meeting, where I'm sitting, is being held on the traditional lands of the Wurundjeri people of the Kulin Nation. I recognize the Aboriginal and Torres Strait Islander people's continuing connection to land, water, and community, and pay my respects to elders past and present. So where I'm at today in a hospital setting at VCCC is a perfect example of how point-of-care tests and near-care tests have been, I guess, seamlessly integrated into patient care in all shapes and sizes. But what is surprising really is how severely underutilized infectious diagnostics, point-of-care diagnostics, have been used for infectious diseases. We have a clear global problem that accurate diagnosis of infectious diseases overall relies heavily on centralized laboratories that require expensive equipment and specialized personnel. And what this means is that we're really limiting access, in particular to low-income settings and in our remote regions. So in Australia, it can take over 2 weeks for a clinical sample to be processed from remote regions where our Indigenous communities are, and that's on a good day. We have an alarmingly low number of testing platforms. So like during the COVID outbreak, for example, we saw quite rapidly critical shortages in reagents leading to extreme delays. So the WHO has acknowledged the need, I guess, for new innovation in this space and has established what's known as the assured criteria. And these are essentially just benchmarks that new diagnostic needs to achieve in order to be approved. And since the COVID pandemic, we've seen a flurry of new innovations being applied in this space, but they all vary in their, I guess, ability to achieve these benchmarks. And so what we're seeing more and more is, I guess, researchers trying to combine multiple methods to achieve these benchmarks. And so I'm not sure if you can see my mouse, but within our team, we combine isothermal amplification, which is, I guess, making copies of your target at a single temperature. So all you need is a heat block, and this really builds your sensitivity. And then we're combining this with CRISPR-Cas diagnostics, which are well known. The technology is well known to increase specificity in your assay. What these benchmarks, I guess, don't really highlight is the nuances in designing an assay. So I'm not sure why the slide looks a bit different, but essentially, not one size fits all. We have to consider use cases. For example, what do I mean by this? In a home setting, a lateral flow strip may be great using an easy self-collection sample that's easy to self-collect. But in a hospital setting, you might require an instrument that has connectivity so that you can connect to centralized patient data. And so what we're really looking for is technology that is highly amendable to these different use cases. Which brings me to CRISPR technology. So I guess what is CRISPR technology and how is it used for diagnostics? Essentially, CRISPR technology exploits a naturally occurring enzymatic reaction, which involves two main components. The first is a guide RNA, which when introduced to your clinical sample will bind to a matching target region on the pathogen sequence. And this binding will recruit a Cas enzyme. Once this Cas enzyme complexes with the sequence and the guide, it becomes activated in a very specific manner and will cut the pathogen DNA or RNA. What's important to note in the case of a diagnostic is that once this, once this Cas enzyme is activated very specifically, it remains on, but now it can undergo non-specific cleavage. And so you can introduce a reporter, which will also be cleaved. And it's the omission of fluorescence from the cleavage of this reporter that we're actually quantifying in a diagnostic. And so because we're quantifying a fluorescence signal, you can actually use multiple different readouts. And to complete the picture, if you have a negative sample, there's no target DNA or RNA for your guide to bind to. Your Cas enzyme remains inactive and your reporter intact. So as I alluded to in the previous slide, the Cas technology is highly amendable because you can introduce multiple guide RNAs to target independent regions on your sequence. So this will prevent diagnostic escape. And you can introduce multiple Cas enzymes with different unique characteristics. So you can introduce a Cas enzyme that targets DNA and DNA reporters, and you can introduce a Cas enzyme that targets RNA and RNA reporters. And this way you can multiplex multiple pathogens. So we're currently using this technology to develop assays for a range of different use cases. We started our work in this space really to address a critical need in our remote settings for developing a point-of-care test to detect STIs. Unfortunately, in Australia, our Indigenous community is disproportionately affected by STIs and hence the need. We've entered quite an exciting stage of development where we've validated these tests in the laboratory. And then early next year, we'll be starting a field trial at Melbourne Sexual Health Centre, which is the largest health centre in Victoria for the field. So the two assays that I really want to talk to you about today, first is an example of an assay we developed for an emerging pathogen, as well as obviously how we hope to use this for our next big challenge, which is fungal pathogens. So as we know, in 2022, we had the first global outbreak of Mpox infection. And just as a bit of a reminder and a bit of context, in under 6 months, we saw over 80,000 new cases of Mpox in over 110 countries. Cases were predominantly amongst men who had sex with men. And what's important here is that the diagnostic gold standard then and now is predominantly PCR in centralized laboratories. So again, facing those challenges of access. So this is the assay, and as you can see, it's quite modular. There's a lot of steps. It doesn't look like how you would envision a point-of-care test, but in the initial stages, we really try and keep the steps modular so that we can optimize each step. So it starts with sample collection, and then we extracted the gDNA within the laboratory, and then introduced an isothermal amplification step. We use RPA. And as I mentioned earlier, this essentially is creating copies and increasing the sensitivity. Then the amplified product is introduced to the CRISPR reaction. And then we use two different fluorescent readouts, really just to show that the technology was amendable. One was a fluorescent-based assay using a plate reader, and the second lateral flow strips. So the first question we wanted to answer is, well, how sensitive and specific is our assay? So in order to answer this, we introduced a serial dilution of control monkeypox virus DNA through the assay. And we're very pleased to see that we were detecting single copies of monkeypox virus, shown in yellow. And then we also introduced a control panel of viruses related and pathogenic, their DNA, and saw no cross-reactivity against this panel. So this was fantastic. And then we next wanted to test it on clinical samples. So essentially, we were privileged to be provided with 185 clinical samples, including oral, anal, and skin lesion specimens from the Victorian Infectious Disease Reference Laboratory. We were provided these blind and essentially ran the gDNA through our assay and compared it with PCR. And we're pleased to see that we were able to detect all the true positive samples, achieving a sensitivity of 100%. And all but one sample we correctly called true negatives, reaching a specificity of 99.3%. So really pleased with this result. And I should mention that the results were consistent between using the fluorescent readout and the lateral flow readout. So as you're probably aware, we're now in our second wave of Mpox outbreak. So there's a lot of interest in seeing this assay at the point of care. So we're currently in the stages of consolidating the steps onto this portable device, which fits in a briefcase. So now I'd like to, I guess, switch gears a little bit and talk about the rationale and design of the CRISPR diagnostic that we're proposing to develop for Aspergillus infection. And so I think, obviously for this group, I don't really need to get into the basics of why this is important, but I do think it's important to reiterate the need for early diagnosis. So we know that there's data to suggest in Australia that having an IFD will increase your chances whilst you are undergoing cancer treatment, increase your risk of mortality upwards of 30%. So needless to say that we really need to diagnose these infections as early as possible to facilitate interventions that I think we've already seen today are typically highly complex cases. It's also noteworthy that here, high-risk patients routinely will receive antifungal prophylaxis. And although this is completely justified, we need to acknowledge the risk of promoting antifungal resistance within our community, which will then lead to treatment failures and, again, further complication. So as we know, the preferred treatment choice for IFDs, including Aspergillus fumigatus, is azoles, which kill by targeting ergosterol production, sorry, tongue tie, which ergosterols are important for critical components of fungal cell membranes. We know that there's an increased prevalence of resistance to these azoles, but to be honest, even if the rates are not incredibly high, even a small amount of resistance circulating is enough to ring alarm bells, because as we know that there are certain infection manifestations that heavily rely on this group of drugs. So we know that mutations in the CYP51A gene, which encodes the target protein of these azoles, can lead to resistance. And to date, there's about 15 different mutations of this gene that has been attributed to this resistance. But the majority of cases we're seeing is due to a substitution of a leucine to a histidine in this gene, coupled with in the insertion of 2 copies of a tandem repeat sequence in the gene promoter. So that's just important information to keep in mind here. So what are the tests available for diagnosing IFDs and determining resistance status, at least in Australia? But I'm sure this is also the case globally. Much like the other infectious diseases, diagnosis is reliant on centralized laboratories and includes PCR, galactomannan detection, and antifungal susceptibility testing is still by culture. So what's the consequence of this? It takes a long time. PCR can take over 48 hours to receive results. Culture, three days. And these are all under like optimal conditions. And so when we're talking about early diagnosis, this really doesn't cut it. And needless to say that in Australia, there are no approved point of care tests for IFDs. So this is the assay that we aim to make. We're proposing to make a tripleplex detection assay using the CRISPR technology that simultaneously detects but distinguishes between Aspergillus species, fumigatus, as well as the CYP51A mutations. And this assay will be available on this portable instrument, which we, based on our previous assays, anticipate will take approximately 40 minutes and be performed at a single temperature. So one of the major challenges, I guess, or bottlenecks of developing a CRISPR diagnostic is the complexity of designing the guide RNAs that bind to the pathogen DNA. And this is because the targets need to be highly conserved regions, but also compatible with the CRISPR reaction. So Sujan, an amazing bioinformatician in my team, has developed a bioinformatic pipeline that can essentially take all of the publicly available genome sequences out there, search them for conserved regions, but also simultaneously make sure that they are meeting the criteria of a CRISPR technology. So leveraging this data set, we're going to, this pipeline, we're going to find target regions that are conserved within all Aspergillus species, those unique to fumigatus, and then, of course, the mutations. So what is the technology behind it? How are we going to achieve this? Essentially, we're going to exploit the unique properties of these Cas enzymes that I described. Some that target the DNA and some that will target DNA translated to RNA. We've had a lot of success with this approach for the STIs, where we're multiplexed 2 pathogen detections, but this will be our first attempt at 3, but I'm very confident. This is actually my last slide, but I guess it's not the most optimistic slide, but I wanted to really acknowledge the complexity of trying to detect a fungal pathogen. I think it's a perfect example of how different use cases come with different challenges, and we can't just rinse and repeat an assay. We're dealing with something very different from the bacterial and viral diagnostic tests. We've got a huge genomes that have conservation with human genes, which will come into, which will be important considerations. The biomarkers for antimicrobial resistance, antifungal resistance, sorry, not that well documented. There's not a lot of data that's convincing data that suggests that a mutation will always lead to phenotypic resistance. And so this is a space that we'll be spending a lot of energy growing the research in. Timing. How are we going to distinguish between the presence of a fungi versus its invasive nature? Will sensitivity in our assay resolve this? The fungal morphology itself. Can we actually access the fungal DNA at the point of care using rapid extraction methods, or will we need something that requires additional equipment? What sample types work? We don't want to get invasive and use serums, but I think in the clinical setting, that might be the best way to go if we want to achieve reliable results. And then finally, somewhat of the most important consideration is acceptability. What needs to be achieved by this test? What questions do we need to answer with how much confidence to actually result in clinicians using it and being able to clinically act on the result? So I'd like to just end by acknowledging the people involved in the work that I presented and the work of the future. Sujan is my bioinformatician, and Matt is in the lab, has hands of gold. He does all of the assay development, as well as the team at the Peter Mac, in particular Michelle and Monica, who, you know, these assays can't be built just in the lab. We really need the clinicians who are facing the patients, who are going to use it, to be part of the conversation from the get-go. And I think they match my enthusiasm in really, I guess, creating options to address detection of fungal pathogens as early as possible. And I'll end there. Thank you.
Thanks so much, Shivani, for a fantastic presentation. Exciting to see that we might have some point of care diagnostics in the pipeline. So I'm Abby Douglas. I'm an ID physician and postdoctoral researcher at NCIC. And just this final 10 minutes or so, we're going to address some questions, and if time, we'll open up just for a bit more discussion. We've got Monica Slavin joining us, of course, and Dimitrios Kontoyiannis. Thank you for hanging around. We really appreciate that, as well as David Gottlieb and, of course, Shivani Pasricha. So I do have some questions here to start things off. One was essentially for David. How do you tend to manage the immunosuppression around T-cell infusion, in particular if someone's on steroids? Do you dictate the change in immunosuppression in that setting?
Yeah, I mean, steroids are clearly, you know, the Achilles heel of T-cell therapies, and then, you know, we don't have a huge amount of expertise in the fungus T-cell space. In the virus T-cell space, where we have a lot of experience, we have basically said that anybody who is on 1 milligram per kilogram or higher of prednisone, or you know, whatever the steroid equivalent is, we don't think there's any point giving T-cells under those circumstances. As you saw from my presentation, a lot of the patients that we treated have actually had graft versus host disease, and you know, that was the same in the fungal space. It's generally possible, if you can get the graft versus host disease under control, to get the steroid dose down to below 1 milligram per kilo. But I just say to people, don't bother giving the cells if you know, in that situation. I think calcineurin inhibitors are less of a problem. The cells don't immediately apoptose. There may be some inhibition of function, but we certainly have seen in the viral situation that those cells still work. So yeah, those are my kind of rules of thumb, I guess.
Fantastic. Thanks, David. A question for Dimitrios. In your setting at MD Anderson, do you use immune checkpoint inhibitors or granulocyte infusions in your in some of your tricky fungal infections?
Yeah, I mean, we have more experience with white cell transfusions. Typically, we avoid them in excessive pneumonias because we have seen TRALI, you know, lung toxicity on those. I'm a big skeptic of using them in closed space infections like compartment syndrome, orbital infections, and they have a lot of use, especially in leukemia, less in transplant, in severe perirectal infections, disseminated fungal infections, typically multi-drug resistant infections. But maybe I have been doing that for so long and I have become a little bit cynical on this. When we use them a lot for fusariosis, for example, that we have a lot of fusarium infection here. The ultimate driver is whether the patient is going to go to remission or not. So in other words, if you have a patient with refractory leukemia, nothing can be done, and we try to prolong life with white cell transfusions, yeah, they work some, they make antifungals better, but those are bridges to somewhere. If there is no bridge on the other side of the river, and there is a lot of use and abuse in our leukemia service for everybody, and there is no thoughtful stratification who might need them. The other thing that we haven't talked about because of time, there are a couple of papers from Europe using white cell transfusions as secondary prophylaxis in patients who have multi-drug resistant infections, fungal infections, where they're going to get transplant or they're going to get cytotoxic chemotherapy with good results. And I have done it in my own practice. A patient with disseminated mucor infections who goes to chemo, and my anecdotal experience, obviously we need to be careful with the anecdotes, have been very good, like using them preemptively in the setting of immunosuppression. But one question I had for David, I'm not sure if how much you touched on this. When we look in CAR T therapy for fungal infection in our paper in NBio, we have seen a lot of tremendous donor-to-donor variability in the quality of T cells to kill fungus. And how much this individual variability it is this something that is going to plug both the targeted therapy and the pleiotropic T cell therapy? And the other question, Sebastian Wooster, who is in my lab, has done some work in Germany before he came, when he looked for reactive T cells in healthy volunteers due to prior occupational exposure, or if they were carpenters or residential exposure. And I was wondering if in the future you might be thinking doing a T cell assay and enriching patients who have already T cell exposure because of their profession.
Yeah. So is there a lot of inter-donor variability? We haven't seen a huge amount of that. We make our products, and as usual, when you get into the clean room and you start to make these products in the clean room, it gets a little more difficult because you're using different reagents and you've got to use GMP grade reagents and things. And we find, at the end of the day that, our products that we make in the clean room aren't perhaps quite as good, in inverted commas, in the sense of their reactivity as the ones that we made on the bench using all sorts of reagents that are not GMP grade. Nevertheless, we get pretty consistent reactivity. I think it would be quite easy to set up a test to assess normal individual reactivity. So we look for activation and we purify the cells after activation, following overnight stimulation. So we look for activation markers. No problem looking at those: CD137, CD134, CD69. You can use a whole variety of those things. You could even think of doing a TNF assay, some kind of cytokine assay. It would be really interesting to know, is a person who is engaged in the construction industry more likely to have a lot of these sorts of cells in their blood than someone who sits and does a desk job? I don't know the answer to that. We haven't looked at that, but it's an interesting idea. I think it's something that could be pretty easily done. I'll have to go and find some construction workers.
If you are interested, I can send you this paper, because they use a simple T cell assay, to kind of stratify prior exposure. Because if it's going to be expensive and cumbersome, maybe if you have 10 donors and one works as a carpenter or in construction, to me it makes sense to go with him.
Yeah, I think that's right. We really want to make cells. The cells that we make are not, it's going to be expensive, like all cell therapies are expensive, but it's not going to be in the hundreds of thousands to millions of dollars, because these are not genetically modified, which is the beauty of our process. The downside of our process is, of course, that you could make the argument, okay, you're making a lysate, you don't know what's in this lysate, and so on and so forth. Nevertheless, I think the lysate can be characterized by things like 2D gels and mass spec and all that sort of stuff. And I think you can make a big batch of this lysate in a GMP consistent way, and use a tiny amount. So if you made a master bank, you could keep that master bank and probably make literally thousands of products. So I think it's doable, and I think you could set up such an assay as you've described an activation assay, and then you have to see whether that's important. My own personal view is I would rather take the guy who's HLA-DR homozygous than the guy who's necessarily a construction worker, unless those kind of experiments that you've alluded to tell me that he's going to be way better. But that's just guesswork, right?
Fair point. I understand what you're saying. Yeah.
So Michelle has a question for David as well, basically saying the clinical trial results to date are impressive. Are there any other requirements for the third-party donors other than HLA partial match? And do you assess for prior Aspergillus exposure?
No, we don't, because we just assume everybody's exposed to Aspergillus. So, you know, obviously when we make CMV, EBV specific T cells and all, you know, like everybody, we look for serology. You've got to be seropositive. But, you know, when we make BKV specific T cells or VZV specific T cells, we don't bother with that because everybody's been exposed to BKV. Like everyone's BKV exposed, everyone's HHV6 exposed. Yeah, I mean, you will find the odd donor, who may be an adult donor who's not VZV exposed, but it's really, really uncommon. Same with BK. And you know, we haven't done a systematic analysis of the sort of things that Dimitrios asked me about. So I just make the assumption that everybody is Aspergillus exposed. You know, you'll look in the fridge and stamp on the carpet and all that sort of stuff. So I assume that's the case, but maybe we should really do that.
Great. Monica has her hand up politely.
I just wanted to also ask David a question. You showed a really nice response in those CNS disease patients. So do you understand how and how much of those T cells get into the CNS? And does that bring with it any other toxicities at all with the T cells?
Yeah, look, the answer is no, Monica. I don't know how many T cells get in. It was really unfortunate that the young man who didn't agree to the trial wouldn't agree to have samples collected. And so he went to theatre twice because the neurosurgeons were so concerned about what was happening in his ventricle, and they saw all this debris. And when on the imaging, there was, you know, what I assume was just pseudo progression on imaging, you know, would have been nice to get some of the cells that were in there and analyze them and see what they were. So I don't have the answer. We do know in CAR T cell therapies for malignant disease, of course, that we know that the CAR T cells get into the CNS and they do traffic through the brain. So I am drawing the assumption without any proof whatsoever beyond that kind of relatively weak proof that I showed you from the murine experiments that were done in Luigina Romani's group, where you know, these T cells ablated any colony formation in the brain in a, you know, I admit very small number of, you know, mice. So take that for what it is. But I just don't know whether the T cells that we infused have actually trafficked through the brain and have helped. All I know is you saw those two patients, the young woman with the really big frontal abscess and the young man who had that really, what was a really deep fungal infection, and they got away with it. And, you know, I thought both those patients wouldn't make it, but they did. Now, call it what you will. Beginner's luck, maybe, you know, I just don't know.
Thanks so much, David. We have lots of other interesting questions we could ask, but we are running a little bit low on time. So really thank you so much for all your wonderful comments and thoughts in your presentations. And I'll hand back over to Monica.
Oh, thank you, Abby. I think it just falls to me to close the meeting, to again thank our sponsors today, Pfizer, to thank the organisers, the organising committee, and our wonderful speakers. It's been amazing to hear from you all about these frontiers in fungal infection. And for a very long time, it's been very static in the field of fungal infections. We've had our standard diagnostics, we've had our standard treatments, but this is a very exciting new frontier, moving more towards personalised therapy. And I think you're all working on these frontiers. So I thank you very much for your contributions today and look forward to hearing about your future research as well. Thank you. And goodbye to everyone who joined us. We had